Welcome to the deep dive. If you're an orthopedic resident prepping for exams like the FRCS or, just really want to get your head around complex injuries, then you're definitely in the right place.
That's right.
Today, we're tackling distal radius fractures. Super common, right?
Yeah.
But surprisingly complex when you dig into them.
Yeah.
And we'll also cover a nasty complication. Post-traumatic radioulnar synostosis.
Yeah. Getting these right is fundamental. It's not just about exams. It's about getting your patients functioning well again.
Exactly. Now, this whole deep dive is built around the Ortho Made Simple notes. You can find them over at mokyingren.sg. They're put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, finished his FRCS back in 2022. Really fantastic stuff.
He's done a great job distilling it.
Yeah. So our mission today is to unpack the really crucial bits for you. Okay, let's jump in.
Sounds good. It's a core topic, so getting these concepts nailed down is, well, essential for residents.
Couldn't agree more. So you're faced with a distal radius fracture. You've got the x-rays up. Where do you even start with classifying it? And why does the classification actually matter so much?
Okay. Yeah, classification is basically your first step, your immediate roadmap. It gives you a common language,
Yeah.
and definitely guides treatment. We mostly use two main systems.
Right.
First, you've got the AO trauma classification. It's fairly broad. 2.3A is extra-articular, 2.3B partial articular, and 2.3C means it's completely involving the joint, often comminuted.
Okay.
Then there's Frykman. And Frykman is, well, really practical because it focuses specifically on whether the DRUJ, the distal radioulnar joint, and the radiocarpal joint are involved.
Oh, okay.
So Frykman 1 is extra-articular, 3 involves the radiocarpal joint, 5 gets the DRUJ, and 7 means both are involved.
And the even numbers, I remember there was a trick.
Exactly, yeah. The even numbers 2, 4, 6, 8 just mean there's an associated ulnar styloid fracture tacked on. So it's a quick way to size up the whole injury pattern, really useful for exams too.
Gotcha. And then, of course, the eponyms. Collins, Smith, Barton, Chauffeur, they pop up all the time. What are the key things you look for to tell them apart quickly?
Yeah, these are the classics. They describe very specific displacement patterns, which helps you visualize things fast. A Collis fracture, that's the classic one, right? Dorsal displacement gives you that dinner fork look sometimes.
Right.
Smith is the reverse volar displacement, think garden spade. Barton is different. It's an intra-articular shear fracture. So a chunk of the joint surface breaks off and shifts, could be dorsal or volar.
Okay, a shear.
And Chauffeur is a radial styloid fracture, often from a direct hit, like the old car cranks, That's where the name comes from. Knowing these helps you anticipate the anatomy involved.
Okay, so beyond just seeing the pattern and classifying, what about the numbers, the radiological parameters we have to measure? I always think of the rule of 11s. Is that still the main thing?
The rule of 11s is absolutely still relevant. It's a great benchmark. It gives you clear targets for what normal looks like anatomically, which is what you're trying to restore.
Yes. Oh, remind us.
Right. So radial inclination, ideally around 22 degrees. Volar angulation, aiming for about 11 degrees. And radial height, roughly 11 millimeter. Getting close to these isn't just about making the x-ray look good.
No, it's about function.
Exactly. It's about restoring the wrist's biomechanics. If you're off by too much, the patient might end up with pain, stiffness, limited motion. So yeah, hitting those numbers or getting as close as possible is fundamental.
Makes sense. Now here's a concept that really shifts your thinking. The Brickley and Regazzoni 3-column theory. It's not just bone, it's functional columns. Can you break that down?
Yes. This is really key for surgical planning. Brickley and Regazzoni force you to think about the wrist's functional architecture. It's not just one bone breaking. You have 3 columns. The medial column, that's your distal ulna, and the TFCC. Think of it as the main stability post on the ulnar side. Then the intermediate column, this is the workhorse, the lunate fossa, the medial part of the distal radius, takes most of the load, needs perfect reduction.
The weight-bearing part.
Precisely. And finally, the lateral column, the scaphoid fossa and the radial styloid. This one's critical for getting your length and alignment right. If you ignore one column,
the whole thing's compromised.
Exactly. The whole system doesn't work properly. So understanding these columns really dictates your surgical strategy. You need to restore all 3.
That's a great way to think about the reduction goals.
Right.
But then how do you predict if a fracture is just going to collapse or displace, even if you get a decent reduction initially? What tells you this is likely unstable?
Predicting stability is probably one of the most critical judgment calls. We look for red flags. LaFontaine's criteria are still very useful. 5 things: age over 60, dorsal comminution, Significant dorsal angulation. Is it intra-articular? Is the ulna fractured too? If you tick 3 or more of those boxes, you should consider it unstable. It's likely to displace in a cast.
And wasn't there another set of criteria?
Yeah, McKinney's predictors from 2006 are also helpful, focusing on things predicting failure of non-op treatment. They highlighted age over 80, significant comminution, and positive ulnar variance, meaning the radius is shortened relative to the ulna. These help you decide early on if surgery might be needed.
Just a reminder, this deep dive is based on the Orthomaid Simple Notes from mokyingren.sg. Okay, we've got the planning down. Let's talk procedure. Beer's block, pretty common for these. Can you walk us through the steps? And crucially, how do you avoid lidocaine toxicity? That's always a concern.
Right, Beer's block. Very effective, but safety first, always. Step 1, get a second IV line in the other arm. That's your safety net for resuscitation if needed. Have the crash cart nearby.
Essential.
Then, apply your tourniquet on the affected arm. Inflate it, typically about 100 mmHg above the patient's systolic pressure. Then you inject the local anesthetic.
Lidocaine usually. What dose?
Yep, lidocaine, it's an amide. Standard dose is 3 milligrams per kilogram using a 0.5% solution. You can make that easily. Just dilute 1% lido with an equal volume of saline.
Okay. And the cuff time.
Critical point. Keep that cuff inflated for at least 20-25 minutes after injecting. This lets the anesthetic work and stops it rushing into the system. Max time is usually 60, maybe 90 minutes, absolute max.
And deflation, you don't just drop it.
No, definitely not. Stage deflation is key for safety. Deflate it for maybe 10 seconds, then immediately reinflate. Wait about 45 seconds, watch the patient closely, no issues. Deflate again for 5-10 seconds, then reinflate. Repeat one more time, then you can take it down fully.
Okay, staged. Good tip.
And all through this, you're watching for toxicity signs. Headache, dizziness, weird taste, ringing ears, progressing to cardiovascular issues or seizures if it's severe. Vigilance is key.
Absolutely. Now, a common scenario. Patient has the distal radius fracture and carpal tunnel syndrome. What's the incision strategy there? Do you try and do it all through one?
No, the recommendation is definitely separate incisions. Use your standard Henry's approach for the forearm fracture fixation, then make a completely separate standard carpal tunnel incision distally.
Why separate?
It's all about protecting the palmar cutaneous branch of the median nerve. It runs superficially there, and trying to connect the incisions puts it at real risk. Separate incisions avoid that headache. Small detail, big difference.
Good point. Okay, let's pivot to specific patient groups. How do you manage an unstable distal radius fracture in an elderly patient, maybe with lower functional demands? The goals seem different here.
Yeah, very different. You really have to consider the whole patient, their activity level, comorbidities, expectations. The 2013 AAOS guidelines give some direction here. But what's really telling are studies like the Aurora RCT in JBJS from 2011.
What did that show?
It was a big study comparing ORF surgery with plates and screws versus just casting for displaced, unstable fractures in patients over 65. And the punchline was no significant difference in patient-reported outcomes, like pain or function, between the two groups, even though the x-rays looked much better in the surgery group.
Wow, okay, so better x-ray doesn't always mean better outcome for the patient.
Exactly. It really makes you question what you're optimizing for. In this group, maybe perfect radiographic alignment isn't the main goal. Maybe it's just comfort, getting them back to their baseline activities quickly and safely. It's a conversation you need to have.
That's crucial for residents to hear. But, okay, say you manage that patient non-operatively, and they come back at 8 weeks. The fracture's healed, but with a deformity, and it is bothering them, interfering with daily tasks. What then?
Right, so if they have a symptomatic malunion that's genuinely limiting their function, even if the initial non-op decision was sound, then you definitely consider intervening. A corrective osteotomy of the distal radius is the way to go.
How would you do that?
Usually through an extended FCR flexor carpa radialis approach, using a volar locking plate to fix the corrected alignment. The goal is purely functional improvement at that point.
Okay. Now, complications. Tendon ruptures, patient comes back, can't extend their thumb. What's likely going on?
Thumb extension loss usually points to the EPL extensor pollicis longus tendon. It often ruptures from rubbing over Lister's tubercle, either from the fracture itself or sometimes the hardware. It's not super common, maybe 1% of cases.
How do you test for it properly?
You use the retropulsion test, have them lift their thumbs straight up off the table. Critically, don't just test IP joint extension because the EPB, extensor pollicis brevis, can sometimes trick you. Ultrasound can help confirm the rupture.
And if you need to reconstruct, say with an EIP transfer.
Right. EIP extensor indices proprius transfer is a common solution. Before you do it, you need to check the EIP is present and working. You can isolate it by having the patient flex their other fingers, which relaxes the main EDC tendons. The EIP is usually just ulnar to the EDC tendon going to the index finger.
Got it. And the surgery itself for that EIP to EPL transfer, what's involved?
Typically 3 incisions. A small one dorsally over the index metacarpal head to harvest the EIP tendon. A second, longer one more proximally on the wrist, midline dorsal, to find the EIP and bring it out from under the retinaculum. And a third incision over the thumb metacarpal to find the distal stump of the EPL.
And you connect them how?
You pass the EIP tendon subcutaneously towards the thumb and weave it into the EPL stump using the Pulver-Taft weave technique. It's a strong, reliable connection. And this brings us to the general principles for any tendon transfer. The 9S principle is great for exam recall. You need a supple joint and aseptic bed.
Okay.
And the donor muscle needs 6S qualities. Strong enough, it'll lose about 1 grade of power. Sacrificable, you won't miss it too much. Sufficient length and amplitude, think Smith's 3-5-7 rule for excursion. 3 centimeters for wrist, 5 centimeters for finger extensors, 7 centimeters for finger flexor.
3-5-7, right.
Also needs to be synergistic, if possible, firing naturally with the lost function. Provide a straight line pull, and ideally single tendon for a single function. Finally, you need a suitable patient, someone motivated for the rehab.
That's a really useful checklist.
Oh.
Okay, flip side. What if the patient can't flex their thumb?
Okay. Inability to flex the thumb points to the FPL flexor pollicis longus. Again, often an attritional rupture, commonly rubbing on the edge of a volar plate.
Investigation.
Same idea. Ultrasound is usually your first step to confirm the rupture and see if it's right at the plate edge.
So pulling it together for both EPL and FPL ruptures after these fractures, what are the management options?
You've basically got 3 choices. Tendon graft, tendon transfer, or fusion. Which one you pick depends on timing, patient factors, tendon quality.
Okay.
Often these are attritional, so the tendon ends are frayed, making direct repair tricky. For an acute rupture, if the muscle's still good, maybe a graft palmaris longus or a strip of XCR woven in.
And chronic?
Chronic, especially with muscle wasting. Transfer is usually better. EIP to EPL, like we discussed. For FPL, you typically use an FDS flexor digitorum superficialis tendon, usually from the ring or middle finger.
And fusion?
Fusion, like thumb IP joint fusion, is more for lower demand patients, or if other options fail. Gives stability, but sacrifices motion. And remember, YPL isn't great for FPL transfer.
Too weak.
Exactly, just doesn't have the power needed for thumb flexion.
Right. Okay, let's switch gears again. Young patients, or maybe high-functioning older adults, how does the approach change for them? Anatomy and early motion seem much more critical.
Absolutely. For your younger active patients or older folks who are still very active, the goals shift. You're aiming for a near-perfect anatomical reduction to enable early movement, prevent malunion, and really minimize that risk of later arthritis.
So surgery is almost always the answer here.
Pretty much. You want to restore those 3 columns, Rickley and Regazzoni, again, especially getting the joint surface, the lunate and scaphoid fossae, perfect. That usually requires ORF.
Any specific tricks during surgery? Or special x-ray views you rely on, particularly with volar plates?
Yeah, a couple of things. Releasing the brachioradialis insertion can really help get length and reduce the fracture. Temporary K-wires are your best friend to hold the reduction while you plate.
And x-rays.
Crucial views. For volar plating, you need skyline views, wrist flex straight down, beam along the bone to check for dorsal screw penetration. You do not want screws irritating extensor tendons.
Definitely not.
And the 22-degree elevated lateral view. Forearm lifted 22 degrees off the table, beam comes in laterally. This one is the best for checking if screws have gone into the joint. Essential views to avoid big problems.
Makes sense. What about dorsal versus volar plating? Any key differences in complications?
Volar plating is much more common now. The main thing there is avoiding volar collapse. Dorsal plating isn't used as much, partly because of tendon issues.
Which tendons are at risk dorsally?
With dorsal plates, the extensor indices, EIP, is actually the most common one to rupture. The ECRB, extensor carpi radialis brevis, often gets attritional wear. Interestingly, the EPL often gets spared because it's usually handled differently during the approach.
Okay. And the ulnar styloid. Seems like it's fractured half the time. Do you always need to fix it?
That's still debated, honestly. No clear consensus. The big concern is the TFCC attachment and DRUJ stability.
So what's the practical approach?
The rule of thumb is fix the radius first, then check the DRUJ stability. If it's stable after the radius is fixed well, you probably don't need to fix the ulnar styloid. If the DRUJ is still unstable, then yes, fix the styloid. Sometimes just splinting and supination helps stabilize the DRUJ too.
Got it. So fix radius, check DRUJ. Now, you mentioned volar plating is common, but what about the evidence comparing it to, say, simple K-wires for the common dorsally displaced fractures?
Ah, yes, the GRAF-TT trial, Distal Radius Acute Fracture Fixation Trial, published in the BMJ back in 2014. Really important study.
What did it find? Because practice really shifted towards plates.
Well, that's what's so interesting. It was a big multi-center RCT 18 UK hospitals, over 460 patients. Compared K-wires versus volar locking plates for those typical dorsally displaced fractures. And they found, wait for it, no difference.
No difference. In what?
No difference in functional outcomes like the PLE-RWE score at 12 months. No difference in complication rates. No difference in cost effectiveness.
Wow.
Yeah, it really challenged the idea that plates were automatically superior for everyone. It showed that for many common fractures, good old K-wires could give just as good a result. Really underscores needing to follow the evidence.
That's a huge takeaway, especially when considering resource use. Okay, last complication before we move off the main fracture. CRPS complex regional pain syndrome. Tough one. How do you try and prevent it?
Yeah, prevention is key because treating established CRPS is incredibly difficult. The main evidence-based strategy comes from the AAOS guidelines and a trial by Zollinger.
What did they find?
Vitamin C. The trial showed CRPS rates dropped from 10% in the placebo group down to about 2.4% in those who got vitamin C. The recommended dose is 500 milligrams once a day for 50 days after the injury.
Simple enough. Anything else?
Yes, basic things. Avoid casts that are too tight. Don't do really painful manipulations during reduction or therapy. Encourage early, gentle range of motion. Basically, minimize additional pain and inflammation triggers.
Good practical advice. Okay, let's shift to that less common but really debilitating complication.
Yeah.
Post-traumatic radioulnar synostosis, where the radius and ulna fuse together. What puts patients at higher risk for this?
Right. Synostosis severely limits forearm rotation, a huge functional loss. Risk factors, you can kind of group them. Trauma-related ones include high-energy injuries like Monteggia fractures or having both forearm bones broken at the same level.
Okay.
Open fractures, lots of soft tissue damage, bad comminution, even associated head injuries seem to increase risk. And seeing bone fragments floating around the interosseous membrane on the initial X-ray is a bad sign.
And treatment-related risks.
Yes. Waiting too long to operate can be a factor. Using a single incision, like the Boyd approach, to fix both bones that involves a lot of stripping. Screws that are too long and poke through the far cortex. Using primary bone grafts sometimes. And then prolonged immobilization or delaying rehab. All potential contributors.
So knowing those risks, what can you do during surgery and afterwards to try and prevent it?
Prevention really revolves around gentle handling. Using 2 separate incisions for both bone-forearm fractures is key less soft tissue disruption. Meticulous technique. Making sure your screws aren't excessively long. And critically, starting early passive range of motion, especially forearm rotation, as soon as it's safe.
And if it does happen, how do you classify it? And what's the best investigation?
Classification is just by location along the forearm. Type 1 is distal, Type 2 middle, Type 3 proximal. The definitive investigation to see exactly where it is, how big it is, and plan surgery is a CT scan.
When do you operate? Is there an ideal time?
That's another area with no firm consensus. Some say wait 6 months, others up to 2 years post-injury. Generally, you wait for the synostosis to look mature or stable on serial X-rays, meaning it's stopped actively forming.
And the surgery involves?
It involves carefully excising that bridge of bone connecting the radius and ulna. Some surgeons will put something in the gap, like an inconeus muscle or a fascia lata graft, trying to prevent recurrence, but the evidence that interposition actually helps long-term is still pretty uncertain.
Right. And any other tricks to stop it coming back? Like medications or radiotherapy?
Again, no solid consensus. Bisphosphonates work well for preventing HO, heterotopic ossification elsewhere, like after hip surgery. But specific studies on preventing synostosis recurrence are lacking. Radiotherapy has been tried, mentioned in the literature, but it's not standard practice, and the evidence isn't strong either. Early motion after excision is probably still the most important factor.
Okay, so what's the big picture here? We've covered a ton today, from the nuts and bolts of distal radius classification and management to tricky complications like tendon ruptures and synostosis, really vital stuff for orthopedic practice.
Absolutely. I think the key take-homes are Really understand your classifications in radiology. Use the evidence, like the DIAT-TT trial and the AAOS guidelines, to tailor treatment, especially considering the patient's age and function. And always be vigilant for complications. Prevention is key, but know how to manage them if they happen. It really boils down to matching the treatment intensity to the patient's actual needs and goals.
So, as you're studying for exams, or even just seeing your next wrist fracture in clinic, think about this structured approach. How does the classification guide you? What are the stability criteria? What does the evidence say for this specific patient? Applying this thinking won't just help you pass exams, it'll genuinely elevate your clinical practice and how you care for patients. Consider how these details might change your next conversation or your next surgical plan. And remember, this deep dive was based on the fantastic Ortho Made Simple notes you can find at mokyingren.sg.